Hi, my name is Dr. Alan O'Reilly, and I'm a GP and lactation consultant based in Dublin. I've been running a tongue tie clinic for over 12 years. So I just wanted to create this video to help people get a better understanding of the normal lip frenulum and lip tie, and when it might be worth considering having a lip tie released. So everybody has a lip frenulum. It's a normal anatomical tissue. It's the piece of tissue that connects your lips to your gums. Um, you have several lip frenulum, but the one between and just above your upper teeth is the most noticeable. So up there, okay? A lip tie is when your labial frenulum is too short and thick, limiting your upper lip movement, okay? So this would be a normal lip frenulum underneath the upper lip. You can see the upper lip flanges easily and the frenulum is not under any pressure, and this would be very normal and what you would find in most people. So occasionally you can have a lip tie, and this is where the frenulum is very thick or short, and it prevents the movement of the upper lip with any sort of freedom. It's quite restrictive, and when the upper lip is flanged, the lip frenulum becomes white and blanched because it's under such pressure. And you can see the gum blanching as well there as well. Okay, so this would be a significant lip tie. So there are different types of lip tie. Um, Class 1 is considered normal. Class 2 is where it inserts just above the gum line. Class 3 is at the gum line, and Class 4 wraps around the gum line. So generally Class 3 and 4 are more restrictive. So a recent study from the Breathe Institute in California looked at the anatomy of several infants to see what was normal and what was common. So they found that 94% of infants less than 1 year old had a class 3 or a class 4 lip tie. So these were the most restrictive ones, but 94% of infants had them. So it's basically normal when 94% of infants have them. Okay, and then they discovered that only 30%, you can see here it changes. So these are uh, the class 3 and 4, this purple and green here, and then we can see by the time the child is 4 or 5 years of age, all of these children were 4 or 5 years of age, that only 30% had the class 3 or 4, and the rest had a class 1 or 2, okay, which are so much less restrictive. So they realized that the anatomy changes significantly over the first 5 years of life. So as the face and jaw grow, the frenulum usually migrates upward and becomes less prominent. The gum tissue thickens and changes in shape, which alters how the frenulum attaches. And by the time the permanent teeth erupt, the frenulum typically inserts higher above the gum margin. So in infants, a prominent frenulum is usually normal and not automatically a cause of breastfeeding issues. So most upper lip frenula stretch and change over time. Only rarely do they persist in a way that causes dental spacing, like a gap between front teeth or functional issues. Okay. So, in terms of the evidence and opinions that are out there, so the Academy of Breastfeeding Medicine, they believe the practice of surgically treating um, other intraoral, perioral tissue beyond the sublingual frenulum. So by this they mean anything that isn't a tongue tie. So they don't support the release of buccal ties or lip ties. They feel there is no published evidence of improving milk transfer or of reducing maternal nipple trauma in breastfeeding dyads. The upper labial frenulum specifically is a normal structure with poor evidence for intervention improving breastfeeding and therefore cannot be recommended. So the dentists, however, have a different opinion. They believe that in severe instances, a restrictive maxillary frenulum, a lip tie, basically, attachment has been associated with breastfeeding and bottle feeding difficulties among newborns. However, in a prospective study, anatomical classification of the maxillary frenulum as in class 1, 2, 3, or 4, this was not correlated with breastfeeding success or difficulty, pain, or maternally reported poor latch. So the studies suggest a restrictive maxillary frenulum may inhibit an airtight seal on the maternal breast through flanging of both lips. So they believe it's more about how the lip flanges. It's not necessarily about if it's class 3 or class 4, it's how tight it is, okay? So with the lack of understanding of the function of the labial frenulum, the universality of the labial frenulum, as in everybody has one, and the level of attachment in most infants, the release of the maxillary frenulum based on appearance alone cannot be endorsed. So again, it's not just on the appearance, it's about how it functions and how it allows the lip to flange and form that seal around the breast or the bottle. So they believe treatment is suggested when the attachment exerts a traumatic force on the gum, causing the papilla to blanch when the upper lip is pulled. So like that, like in the image from earlier, where we see when we flange the upper lip that the gum becomes white, that the restriction is so severe that it causes this blanching. Or if the attachment causes a diastema, that means a gap in between the teeth wider than 2 millimeters, which is known to rarely close spontaneously during further development. So when a diastema, that the gap in between the teeth, persists into the permanent dentition, the objectives for treatment involve managing both the diastema and its etiology. So pediatric dentists and orthodontists generally agree that most diastemas in the primary and mixed dentitions are normal, are multifactorial and tend to close with maturity. Therefore, any surgical manipulation of the frenulum is not recommended before the permanent canines erupt, and only following orthodontic closure of the space or in conjunction with orthodontic treatment. So, if that gap persists beyond the time that the adult canines develop, so when your child is like 6 or 7, when these adult canines, those teeth on the side, the kind of sharp eye teeth, people might call them, when they develop, if the gap is still there, the Academy of Pediatric Dentistry believe it's worth looking at the lip tie release in conjunction with orthodontic work. So it's important to have a dentist and an orthodontist involved. So closer to home, the Faculty of Pediatrics in Ireland produced a paper in association with the HSE and the Royal College of Physicians of Ireland, and they outright said there's no evidence that lip and buccal ties are true pathological entities, so procedures to divide them should be discouraged. So they have no support for the release of buccal or lip ties for infant feeding, basically. Okay. So, in conclusion, there is limited evidence supporting lip tie release for babies with bottle feeding or breastfeeding issues. The evidence that exists suggests that there may be feeding difficulties with severe lip ties where movement is very restricted. So, if we're seeing that blanching on the gum line. But yeah, I will say it's important to have a lactation consultant involved or a GP that has experience in breastfeeding support, and that can help you get that latch before jumping to a lip tie release. Consider treatment when the attachment exerts a traumatic force on the gingiva, causing the papilla to blanch when the upper lip is pulled. As I say, yeah, thorough assessment with lactation consultant or doctor or dentist with experience in this area before considering lip tie release in infants under 1 year old. And dental concerns, as mentioned, when consider treatment if the attachment causes a diastema wider than 2 millimeters, which is known to rarely close spontaneously during further development. Also, there will be some pediatric dentists out there who express concern about difficulty brushing teeth when there is a lip tie, and I guess that is a dental concern. It doesn't seem to be in the papers or the evidence that is discussed, but it is something that I hear spoken about. Okay.